Good afternoon, everyone. I'm honored that you came to see the Catherine Hawley show. We're here today to talk to you about, it's a device I first saw in 2016 at an ICS conference I was at out in Phoenix. And to me, it caught my attention immediately because it seemed ergonomically logical, and it just seemed efficient. My experience today with Anchorsure is basically kind of more from my experience in the use of it. I'm pretty data driven, you guys know this. And this is a lot of what I'm going to say may be anecdotal, but also may be valuable to you because I'm in the OR a lot. I've used it a fair amount now over the past year, and give you some of my thoughts on it. So what is it? It's an anchor-based system to deliver sutures to the sacrospinous ligament. The main idea from what I gather is that instead of going in a sense around the ligament, it puts an anchor into the ligament at a defined depth. So you know where it's going and how far it's going in. And at least they say potential advantages, less post-op pain. We have data now from Catherine's group that says pain is similar. But I do feel that it is a more controlled and consistent placement, just having done it now a little while. The actual device is a polyether ether ketone peak. It's an exceptionally strong thermoplastic, and been used in orthopedic surgery for a long time. It has 4 edges for stronger fixation. It withstands 40 to 50 newtons, so about 9 pounds. I mean, what's in the ligament, it really holds pretty well. And you don't have to worry about the alignment of the actual anchor with the fibers, because it's going to cross at least 2 ways. And you can see it's very small, pyramidal in design. It can be used for native tissue repair, but you can also use it if you're going to use a graft of some sort. Any type of suture available in the OR, it comes with a Proline. And the anchor allows, as you can see, it allows for placement of 2 sutures, and I can do 2 sutures at the same time. I think the interesting thing here is that the depth is consistent. The depth, you can't go less than 11 millimeters if you place it right. These are data from Catherine Andre's study, overall experience with the Anchorsure device, because a lot of the docs hadn't really used it before. And so it definitely exhibits surgical efficiency and ease of use.
So my passion is in finding the right operation for the right patient. And one of the operations that was really brought to me through transvaginal mesh was the anterior approach to sacrospinous hysteropexy. The data regarding hysteropexy is really solid. And I think that we need to really think about, do you have justification for removing a uterus before thinking that our apical suspension needs to be our routine intervention? But the important thing in recognizing the results of the super trial is our anterior approach to hysteropexy is a good operation. Now, once mesh in the anterior compartment was removed as an option, I was really interested in understanding, could I get the same results doing it with native tissue? And what we found is yes. If you do an anterior approach to hysteropexy compared to hysterectomy, it's quicker, less blood loss. You're not going to injure the ureters or the bladder when you leave the uterus in place. So in my practice, my default thought is, can I get away with an anterior sacrospinous hysteropexy? When we looked at the uphold patients compared to our anterior approach to hysteropexy, we had exactly the same outcome. So I don't think it's so much the mesh anterior apical approach that works. It's doing a good anterior repair, attaching that apical pubocervical fascia to the cervix and getting a really nice cervical attachment from an anterior approach to the sacrospinous. The anterior approach is a smaller dissection than your posterior approach to the same space. I always say it's like entering a room from the front door versus the back door. You get to the same room. From the anterior approach, though, you've got less space. So why does that matter in terms of the tools to do the apical suspension? I used to be a Capio user, but because it works great. But introducing a larger device through a smaller dissection is more difficult. And that little hook caught on the surrounding tissues. And I like efficiency, and I didn't like that. So when we're thinking about, well, what are the alternative strategies? I was like, well, I like the cylindrical shape of this small little tube that I can introduce through my elegant, minimal anterior dissection and put it directly against the ligament and be sure that when it was against the ligament, I was going to deploy the anchor into the space. And why do I care about where the anchor is deployed was because that space that's in the good area is also small. And things can easily go wrong in this space. So when I was first approached about using Anchorsure, I'm a sales representative's nightmare. Because I always say, well, what are the problems going to be with this thing? And show me the evidence. And they were like, well, we don't have that much evidence. And we think it works better, but we don't really know. So I was like, well, we're going to have to study it then. So my hypothesis was that if I don't entrap the levator A9 nerve with a suture through the sacrospinous ligament, but rather had something going into the ligament, would they have less pain? It seemed like a reasonable hypothesis. And so we studied it, and I'm very proud of my fellow Andre Player who took on this project, and it was the editor's choice in the Green Journal. And we studied this and compared the Anchorsure to the Capio. And what we found was that everyone did pretty well. So we didn't have any people with permanent pain. We didn't have to release any sutures. There was no difference in the two groups. And overall, we had one patient actually who had persistent pain at 6 weeks who was in the Capio group. I was really interested in finding out, leaving this anchor in the ligament, was that going to be problematic? And so we did a follow-up of all the patients in the study up to a year and said, like, are you having residual buttock pain? Because I was worried about having to go and dig that anchor out if somebody had pain. Because once it's in, it's in. It's not going to come out very easily. And we found that in that first year after surgery, we didn't have any people with new buttock pain or persistent buttock pain. Everyone did really well. So I haven't had to embark on the journey of digging one of these anchors out. I think it would be difficult. I'm hoping I'm not going to have to do it. But I can tell you that I've put in lots now. We do a lot of native tissue repair, and I've not had a patient that I've had to go and dig it out. So I think if you put it in the right place, it's to a specified depth that you cannot put it in too deep. So I think if you put it in the right place, we know there's not a nerve within the middle of the sacrospinous ligament. And I think that this data was good for me to say I can keep using what I'm using, and now I know that it's safe. So I, in conclusion, think that you need to do more with less. And I think that we need to move towards thinking about more anterior apical support leaving the uterus in place. You don't need mesh, you have the same results, but you do need a minimal invasive device to access the anterior compartment sacrospinous approach.